I don't know how many of you guys were here last time, but I'm Kim. I'm the Global Health Fellow at this center, and I'm introducing Daniel Nicklas, who has a history of working for MGH, where he worked for 8 years on childhood eating disorders, sort of, obesity, and failure to thrive. And then he is working on developing a medical student elective in refugee health and then developing the refugee health clinic here. So welcome. Thank you.
Thank you very much. Thank you very much for having me today. Slides are up there. So, I just wanted to tell you a little bit about myself in addition to that nice introduction. Just so that you know where I'm coming from when I talk about the care of Somali refugee children, which is the topic of today. First of all, I'm not sure if I need to, but I will say that I have no financial interest to disclose. I worked in primary care at Mass General in a town called Revere, which actually is very close to Logan Airport and has a population that is very diverse from around the world. I saw lots of people from Northern Africa, in particular Morocco, a lot of people from Southeast Asia, Eastern Europe, a lot of people from Brazil, a lot of other Latinos in addition. So I have a lot of experience firsthand with treating people from other countries and who may have some cultural differences to our own. We moved here about 1.5 years ago, and my role has really expanded since being here. I do a lot more education now. I still do see patients at the Child Health Clinic, which is the primary care center for Children's Hospital Colorado. But I also had some time where I worked at the Colorado Refugee Wellness Center. I worked there for about 6 months last year, and so again I have firsthand experience with refugees from all over the world. We saw a lot of Somalis there, which I'll be talking about today, a lot of people from Eritrea, a lot of people from Nepal, Burma, and Iraq. So what I want to talk to you about today, my learning objectives are that by the time we are done speaking, that you understand the background and culture of the Somali refugee, that you understand the migration process for the Somali refugee, and really in that case we're really using Somalis as kind of an example or a paradigm for what most refugee families go through to come to the U.S. And I'm going to spend a considerable amount of time on that because I really want a lot of that background is necessary and important to understand the unique healthcare needs of the Somali refugee population here. So how am I going to do that? So I'll talk a little bit in the beginning about just a brief history of Somalia. I'm going to talk about the migration process, both politically and where the rubber meets the road, of Somalis coming to the U.S. as refugees. And lastly, I'll end with some Somali culture and challenges in the U.S. So let's start out with background. So first we have to define who exactly is a refugee. So the 1951 Convention relating to the status of refugees defined what a refugee is, and it is still the most commonly used definition for a refugee used today. The way they defined it is that a person who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or, owing to such fear, is unwilling to avail himself of the protection of that country. Notice in here they say outside the country of origin. So there are a lot of people, which I'll touch on later, known as internally displaced persons. So these are people that are outside of where they grew up or their community, but are still within the legal borders of the country. The geography of Somalia is important in knowing its history. So if you look at the map to your left, Somalia occupies what is known as the Horn of Africa. So you can see that the land juts out, looks like a horn. That is known as the Horn of Africa. Other countries considered in the Horn would be Eritrea, Ethiopia, and Djibouti. excuse me, because it occupies the Horn, the coastline there, it actually has the longest coastline of any country in Africa. So this plays a very important role in terms of its history of colonization. The other thing I want to point out in its geography is if you look between Somalia and the Saudi Arabian Peninsula, that body of water is called the Gulf of Aden. It is not a long, by worldwide standards, not a long stretch of water, and shows the influence geographically of Islam on the Somali culture. So, when Islam started taking place, it did not take a long time for it to take a very, or dig roots in Somali culture. So for over 1,000 years, Islam has been a very strong part of Somali culture. In addition, for over 1,000 years, there has also been a very strong association with sort of a clan culture in Somalia. There are 6 major clans in the culture with subdivisions underneath many of them. So there's maybe 19 or 20, and it's very common in Somali culture to actually, when you first meet someone, to actually ask what is your clan or culture. I'm sorry, what is your clan? And people can often trace back generations in that clan lineage. So as I mentioned before, very long coastline, very important for maritime features of the world in trade, proximity to the Red Sea, very important trade route, and thus both Britain and Italy have histories of colonization in Somalia. Italy left during World War II in 1941. The Brits left in about 1960. At that time, there was a government formed in 1960, had a parliament and a Supreme Court and a constitution. It was not very well established, and thus 9 years later there was actually a military coup. One of the generals of the army named Mohammed Sayed Barre then took power of Somalia. He quickly eradicated Parliament, the Supreme Court, the Constitution. He ruled for the next 22 years. And I just want to point out a couple of highlights of his rule. So he vacillated, during that time it was sort of the Cold War between the Soviets and the U.S., and he vacillated between siding with the Soviets and the U.S. He tried to unify the country and sort of break down the barriers of clan culture. So he forbade people from asking, what clan are you from? People continued the practice, they just did it a little bit more discreetly. It was an oppressive regime. There were executions of certain clans that didn't comply with his rules and regulations. There was actually an attempt on his life in the 1980s, which was unsuccessful. But all of these things together, and actually one other thing, there was a border dispute with Ethiopia in a region called Ogaden, and all of these types of things together caused a lot of strife within the country and led to a lot of insurgencies. So there were not only one, but a few. And all of this culminated in 1991 in a civil war. So the Civil War lasted from 1991 to 1994 and basically was the start of the influx of refugees out of Somalia, and which led to the diaspora of Somalis around the world. I'm fast forwarding now to 2013. The reason that I'm showing this slide, this is a political map of Somalia in March of 2013. It shows that the clan culture is still very, or the country is still very fractured. And so I'm going to show you a slide later. This is the political landscape. I'm going to show you a slide later that shows you where the clans sort of reside in the country. And it follows very much the same distribution that you're seeing here. All right, so let's talk about the migration process for the Somali refugee. Now we know why there are so many Somali refugees. Now let's talk about the process. This is a map from the United Nations High Commissioner on Refugees, which is responsible for a lot of the process of refugee migration internationally. You can see this map is taken from 2012, I believe, and you can see that there are over 1 million Somali refugees in bordering countries. Most of them are in Kenya. There are also prominent populations in Ethiopia and Yemen. And something this map does not show is that there, as I mentioned earlier, there are an additional 1 million Somalis who are internally displaced. So that's 2 million people who have had to move due to a lot of strife in the country. And then the last thing I'll say is that there, in addition, not shown on this map, there's probably another 1 million Somalis, diaspora worldwide, who are resettled in other countries and may or may not have citizenship in those countries. Somali's population overall is probably 12 to 13 million, so that's about a quarter of the population who's been affected by all of this civil unrest. So I'm going to talk about the migration process now, and the way I've structured it is I want you to understand a little bit of the political structure, and then I'm going to talk a little bit more about sort of where the rubber meets the road, what actually happens. And so I'll start overseas, talking about the political structure and then where the rubber meets the road, and then I'll move to domestically, what happens politically, and then also where the rubber meets the road. So how does someone become a refugee? So what happens very commonly is a person presents themselves to the U.S. Embassy or another embassy and says, you know, I think I qualify for refugee status. They're then referred to the UNHCR, so the United Nations High Commissioner on Refugee. They're interviewed. If they meet the right specifications, they're then labeled as a refugee, and the process begins of resettlement. One of the first steps that takes place is that the refugee gets matched with an agency within the country that they're going to. So to focus on the U.S., they get matched with something called a VOLAG. VOLAG is short for Volunteer Agency. There are 10 in the United States that help resettle refugees all throughout the United States. I have 3 highlighted here, and these are the 3 that are mostly active, are the most active in Denver. So one is the African Community Center, which has a website, and you'll see anytime you see a patient, they may have been involved with the African Community Center. It is an arm of the Ethiopian Community Development Council. We also have Ecumenical Refugee and Immigration Services. In other states, that is known as Episcopal Migration Ministries. And then lastly, Lutheran Immigration and Refugee Services. You'll notice, obviously, a lot of these have religious affiliations. I talked about how there's a very strong Muslim culture within the Somali population. These organizations are not supposed to proselytize. That being said, anecdotally, I have heard in my own experiences that people have been asked to pray with the VOLAGs, which from the very beginning sets up a barrier and may partially ruin rapport with VOLAGs. That's anecdotal, and that's only what I've heard from talking to people, but it's there. Okay, so what about where the rubber meets the road? That's the structure politically overseas. What actually happens? So within the refugee camps, a lot of what is done within the refugee camps are sort of organized by both the CDC and the IOM. The IOM is the International Office of Migration. This came out after World War II. The reason that this organization came about was because obviously so many people were displaced after World War II. Its role internationally has grown exponentially in the years since World War II, and they are very largely involved in the migration process for refugees worldwide. So before a person comes to the U.S., we have to, one of the things that is deemed necessary is to make sure that they medically can be cleared to come to the United States. I'm a pediatrician. This is where sort of my focus I forgot to put on my microphone. Sorry. I'll put it on now. That's where sort of my interest has been. So a physician called a panel physician is someone that is responsible for doing this. They are a local physician in the country which the refugee is coming from. They are selected by the U.S. Embassy or the local consulate, and they want to make sure that people that come to the U.S. are medically cleared before they come. One of their primary missions is to make sure that they have some people that are healthy and there's going to be no problems coming, but they also classify people under two classes of medical condition, either Class A or Class B medical conditions. Class A medical conditions may preclude a refugee coming to the U.S. So, I have a lot of diseases listed there, but to think about them in three broad categories, one would be a communicable disease. So something like active tuberculosis or syphilis or leprosy, something that may put the population in the U.S. at risk. That may preclude the refugee coming to the U.S. So communicable disease. The second thing is a mental health disorder. So mental health disorders within the refugee population are super common. No surprise there. A lot of post-traumatic stress disorder, a lot of depression. The key thing with the mental health disorder is it has to be associated with violence or harmful behavior. So it has to be, again, sort of deemed a risk to society as a whole. And then the last thing is substance abuse. So communicable disease, mental health disorder specifically with harmful behavior, and substance abuse. Now, I said it may preclude entry to the U.S. It may not, but they do have to apply for a waiver, and then it has to go through some channels to make sure that they can come. The second type of flag that a panel physician is supposed to identify in an overseas examination is something called a Class B medical condition. This is something that doesn't pose a risk to anyone else in society, but is a serious medical condition and requires close follow-up upon arrival in the U.S., specifically within 1 month. This may be something like congestive heart failure or kidney failure or diabetes or something like that. So this is like rule number 1 in giving a PowerPoint slide, right? Never do this. But I'm doing it. So the reason I'm doing that is not so that you guys look at it and try to look at any of those details. The reason is, and you can listen to me instead of looking at the slide. The whole point of this slide is this is the treatment schedule for presumptive parasitic infections for U.S.-bound refugees administered by the International Office of Migration, but it's prepared for by the CDC. My point on this slide is it is complicated. So people come from different regions of the world, have different exposures to parasitic infections, and then there are different treatments according to, specifically in pediatrics, which is my area, different treatment guidelines according to age and weight, often which kids do not qualify for. And most often, although not always, these examinations are done within 3 weeks of departure. But again, not often. They may have been re-exposed. So why do I tell you all this? Well, because on the back end of it, on our side, when I get there, it's a little bit confusing. And so that's where I'm going with that. Other things that people need to be screened for overseas are tuberculosis. They need a full medical examination, a medical history. Part of the medical examination for panel physicians, in terms of the technical instructions for a panel physician overseas, a GU exam is recommended. It becomes more nebulous when the person is over here, but a panel physician is supposed to do a GU exam, nothing invasive, but also to document if there is any female circumcision, what type of female circumcision it is. And I'm going to get to more details about that in a little bit. All right, so let's shift over to the U.S. now. So the political structure of migration here in the U.S. So at the federal level, one of the cabinets in our government is Department of Health and Human Services. Within that is something called the Office of Refugee Resettlement. And so when you read about migration processes for refugees, you're going to see ORR quite a bit, Office of Refugee Resettlement. What this does is basically it is responsible for a lot of the migration processes and a lot of the funding of the migration processes for refugees in the U.S. and funnels a lot of money to the states to implement the refugee process. There are a few divisions. I think, probably the two very salient ones for me as a healthcare provider and as a pediatrician are the Division of Refugee Health, obviously trying to promote health and emotional wellness, and then the Division of Refugee Assistance. So the reason I put the Division of Refugee Assistance in there is because in pediatrics, so I don't know how many students we have here, but if you guys do your pediatric rotations, always, always, always include your social history. So as one of my colleagues has said to me, in pediatrics, when is the social history not relevant? Well, it is super relevant in pediatrics, and that is because a family's well-being, financially, emotionally, etc., access to resources, is so integral into how well a child does. So when refugees come over, we have to make sure they're healthy. We also got to make sure that they've got the right structure in place to thrive. And it is not easy, and there are a lot of problems with it, and I'm going to get there. Another busy slide, sorry. So I just wanted to, in picture, kind of tell you what the process is, what we've talked about, and this will sort of segue me into the next part of my talk. So we talked, if you look at the left side of the slide, it's basically showing the overseas process. The arrow shows the pairing with the VOLAGs in the U.S. So what happens, we're starting to hit where the rubber meets the road here. What happens when a refugee flies to the U.S.? Well, first of all, how do they fly to the U.S.? So the International Office of Migration pays for their ticket. But it is an interest-free loan. People have to pay this back, or they sign something saying that they will pay this back. So they arrive at the Denver International Airport. They're then met by a VOLAG representative. So the VOLAG representative meets them, welcomes them, and has to have arranged for housing for the person, initial food, furnishings for the apartment, those types of things. So the ORR, again at the federal level, the Office for Refugee Resettlement, gives $1,800 on average per refugee to defray these initial costs. Why am I telling you all this? Well, here's another point of distrust between, and again, this is coming from my own experience in treating Somali refugees and also in focus groups that I have talked to Somali refugees. They have to, and I don't know the ins and outs of why this is done. I assume it's for transparency and accountability in terms of how the money is used. But they tell me that they need to sign something saying, we have gotten $1,800 worth of furnishings in our home. So now I've done home visits for these populations, and they have very meager apartments, mattresses on the ground, dilapidated furniture. It's not new, it's used. And it starts building in this mistrust. This does not look like $1,800 worth of furniture to me. Why am I signing this? So on the other side of it, if you read about it, and again, this is not evidence-based, it's anecdotal, but if you read about it, the ORR does not say you have to use all of this money, the $1,800, for tangible goods. It can cover overhead. It can cover intangible things. And that's probably what the BOLAGs are doing. They're probably using it for a lot of things that are intangible. But again, it creates this mistrust between the VOLAG and the refugee. So the VOLAGs are then responsible for really ensuring the well-being of refugees once they're here in the U.S. And so they have education programs, how to learn English, employment training, job opportunity type of stuff, So there's a caseworker assigned to within each VOLAG, assigned to each refugee. Again, anecdotally, if you talk to a lot of the refugees, Somali or otherwise, they will say that they will call their caseworker a lot and often receive no phone call back. My thought is probably very well-intentioned people, entirely overworked. And so, but again, there's this level of mistrust. And so people don't feel like they're being helped. So the VOLAG caseworkers also, as I was saying before, in terms of the social history, ensuring thriving and wellness, have to set people up with access to food. And so in the very beginning, it's access to food banks and stuff like that. A little later on, as the paperwork sort of goes through the appropriate channels, it becomes SNAPs, which used to be known as food stamps. Again, anecdotally, if you talk to some refugees in the community, there are some places that realize someone is a refugee will take more food stamps than the food is actually worth. Molly, go ahead.
I'm curious to know if, from the point when a family or an individual identifies as needing to, attain refugee status, to when they say sign a paper saying that they've received $1,800 worth of goods, what is the time period for that transition, or is that something that you could generalize at all?
The transition from actually receiving the goods, or
no, basically from start to finish, from declaring their need to become a refugee to kind of achieving that status in the United States. Is it like a year?
Oh.
Through the the panel doctor and the transportation and all of that.
Yeah, so I'm so glad you mentioned that. And so, whenever you prepare these talks, you intend to say things and often forget. But so I really appreciate you asking that question. It can take years. In fact, a lot of the refugees that you will see from Somalia or elsewhere may have their entire identity, their entire lives in the refugee camp. And so I have seen some people who are 21, 22 years old, and that's all they know. So I think that is the more common. And there may be extenuating circumstances in other areas where people come sooner, but I think it is a long waiting game, a long time.
Well, and just like a long period of time to be involved in the bureaucracy of it, and when you actually start a life here, what are the setbacks?
Yeah, so I think it's a good point, and there's sort of a structure to life in a refugee camp that may not closely fit what a life is in any city, let alone a Western city. And so it makes it very difficult. It's a very large challenge for people coming here. The education, too, which I'll touch on a little bit later as well. So food stamps, and then so people also need money for other kind of things that don't fit any category specifically, right? So they need money for food, they need money for transportation, they need money for toothpaste, for soap, et cetera, school supplies, all these types of things. So there's a couple of money assistance programs out there. One is publicly guided by the Office of Refugee Resettlement. It has a few different names. Wilson Fish, I think, is the one that's commonly used here. There's public-private partnership, but it is funded entirely, really, by the Office of Refugee Resettlement. And then there's another one called the Matching Grant Programs, which is administered and funded by the VOLAGs, partially by the Office of Refugee Resettlement, but partially by the VOLAGs. And I am going to tell you a little bit about the differences between those two. I'm going to skip that slide. So the Matching Grant Program, if you look at the top, the cash assistance is shorter than the publicly administered program. In addition, the employment services are also shorter. So why would someone do a matching grant program as opposed to the publicly administered one? Well, the publicly administered one is tied to TANF, so the temporary assistance for needy families. And so the matching grant program may provide a higher income in the short term. This may be appropriate for people You have to keep in mind, a lot of people that come from these countries may be highly educated, PhDs, MDs, you name it, and just have been displaced. And so people who want to get on their feet quicker and maybe need a little bit more money up front may have the matching grant program. The problem with that is there's a limited amount of spaces. Otherwise, most people tend to get the publicly administered cash assistance. Okay, so what about at the state level? So we talked about at the federal level, what goes on. At the state level, the political structure is such that the Colorado Department of Human Services has a division called CRISP, Colorado Refugee Service Program, and they oversee sort of the migration process for refugees into Colorado. So I should have said on average, the U.S. takes about 70,000 refugees per year. In Colorado, on average, about 2,000 of those. Nationally, it's been as low as, I think, 20,000 per year, which was after 9/11, and it's been as high as 130 per year, which I think was after the Vietnam War. It used to be here in Colorado that the Colorado Department of Public Health and Environment would do the screening for refugees. And what happened last year was that the Colorado Department of Human Services thought that it wasn't really the public health department's role to play a direct role in the actual screening of refugees. So what's happened over the last year is that screening process has gone to the community. Most notably, it's gone to MCPN, which is Metro Community Provider Network. This is a primary care network targeted at low-income families, and Denver Health. In Denver Health, there is a pediatrician named Janine Young who's playing a very prominent leadership role, both locally here and also nationally, trying to unify a lot of the screening guidelines that happen domestically once a person comes here. So now let's talk about where the rubber meets the road here. Okay, so we talked a little bit about getting picked up at the airport, we talked about housing, we talked about food, that type of thing. What about health? I should have mentioned, which I haven't, in terms of health insurance, just like a lot of the other publicly administered programs, a lot of refugees will be eligible for Medicaid. If they are not, there's something called Refugee Medical Assistance, which again is put out by ORR, and will cover them for the first 8 months while they are here. So someone's been screened overseas, they have to be screened once they come to the U.S. once again. That is done by a civil surgeon. Panel physician overseas, civil surgeon here. Doesn't mean you're a surgeon. But you have to be an MD or a DO, and you have to be 4 years out of residency. So you have to have 4 years of experience in order to apply to be a civil surgeon. You go through an application process. The United States Commission on Immigrant Services then says yay or nay, and you become a civil surgeon. Part of the role as a civil surgeon is that you need to do mental health screening, which is vital to a lot of refugees coming to the U.S. And then you have to do medical screening. So the medical screening includes reviewing their past medical history, including the documentation that has happened overseas. Anecdotally, again, I can say that documentation is not always optimal, not always the best. And I had alluded earlier a little bit about, so you do a physical exam, obviously. The technical instructions for a civil surgeon in the U.S. are nebulous about whether or not you need to do a GU exam. And it should have been done by a panel physician overseas, but again, in terms of documentation, it can be pretty spotty. A lot of the technical instructions actually are a little bit nebulous, according to the CDC, and I think it's something that Janine is working on with some other leaders nationally. So what about laboratories, laboratory examinations? What do we do? So every refugee gets a CBC with diff. So why do you get a diff? A lot of the refugees we see have low white counts. So you look at, you need to look at what the absolute neutrophil count is, because that is important in terms of infection risk. We think that the white counts are low from malnutrition, and so it affects then also the neutrophilic count. And then also it becomes very important to know what their eosinophilic count is. And so eosinophilia, for those who are not 100% medical here, is associated with parasitic infection, worms, giardia, that type of thing. And so an absolute eosinophilic account over 400 would say that there is a high risk for a parasitic infection, and that you may need to delve a little bit further into that, maybe test for some parasitic infections and or presumptively treat. Nebulous recommendations in the pediatric population about newborn screenings. The CDC recommendation is go with the state guidelines. So there's not sort of a uniform protocol nationally for what to do with newborn screens. There are specific guidelines for testing for lead. Every child 6 months to 16 years old should be tested with a lead level when they come to the U.S. And then once they find permanent housing, they need to be tested 3 months after they get that housing, because there may be a new exposure after they get that housing. HIV is tested for. Tuberculosis, also a little bit nebulous in terms of what sort of testing do we do here. If they have a positive test overseas and they're being treated, or if they're not being treated, they need to start treatment. You do not need to repeat the test. If there's a negative test overseas, you need to review that documentation. It doesn't say whether or not you need to repeat the test. If there's no documentation, you certainly need to do the test. Medically, we're used to giving something called a tuberculosis skin test. It has recently shifted to a blood test, a quantiferon test, to test for tuberculosis for kids over 2. And that seems to be a more reliable way to test for tuberculosis. Hepatitis B is screened for. However, there are no guidelines, really firm guidelines for hepatitis C. This is something that Janine has taken an interest in and has worked on. There are regions of the world where the prevalence of hepatitis C may be as high as 10%. And so she's looking at it with other national leaders in terms of whether or not to screen universally or whether to stratify by country. So I alluded earlier about other parasitic infections, worm infections, that type of thing. And I said a lot of the kids don't fit the right category in terms of maybe not being a right weight, enough weight, maybe not being old enough to be treated prior to departure. And so what do we do with these kids when they come over here? So again, it gets very complicated. Where did they come from? What kind of medicine did they have? How long did they get the medicine before they came? And so is it better to have sort of a uniform approach of universal screening when they come over here? Well, anecdotally, again, that's the practice that I saw more often than not, is that people who came would get a stool O&P. The actual recommendations really say that you have to have either a high eosinophilia count or symptoms of worm infection. So some sort of stomach upset or something like that, diarrhea. The problem with universal screening with stool O&Ps is that you get a lot of false positives. And so what we ended up seeing is a lot of bugs in the gastrointestinal tract that may not actually cause disease, but just may be there, and will not cause disease and should resolve on their own. Well, what do you do with those results? And is that a risk for spread in the community anyway, even though it would be self-resolving? So the other options for people who do not receive treatment prior to departure, you can do serologies, you can presumptively treat, is not really regimented. And so I think this leads to a lot of variation with what happens to refugees once they come here. All right, just a quick review about sort of the rest of the immigration process. So, they get the Medicaid, the Refugee Medical Assistance, Refugee Cash Assistance for the first 8 months. Once, hopefully, they're employed by that time. After a year, they can apply for their green card, which is permanent residency in the U.S., and then after 5 years, they can apply for citizenship. All right, so my last 10 minutes, and then hopefully we'll have some time for questions. I just want to talk a little bit about, I'm hoping that all this stuff I've talked about is led up to this, which is a little bit about the Somali culture, where they're coming from, what they've been through to be here, and what the challenges they are facing here. Because it is vital for us as healthcare providers really to know these things in order to address them. So this is a slide I had alluded to earlier. This shows, again, the clan and family structure of Somalia. And you can see there are 6 major clan groups with approximately 19 subdivisions. And if you recall that political map, a lot of these geographic boundaries actually coincide with the political map in Somalia. Well, they transfer over to the U.S. as well. So a lot of this kind of self-segregation among clans is prominent here in the U.S. Well, let's talk first about transportation issues here. So if you could take a moment and just imagine for yourself, putting yourself in a country where you don't speak the language, you don't know the culture, and you don't know where things are. Try to get from one place to the city. As complicated as this city is, try to get from one end of the city to the next. Well, so I live here, and I've ridden the bus a few times, but I don't really know the culture very well. Do I need exact change when I go? What if I need to transfer buses? Do they give me a piece of paper? Is it just word of mouth? Do I say I already paid? Is there some sort of card like there was in Boston that I tap on a thing in the beginning? Do I need to yell to say, stop the bus, this is my stop? Do I need to press a button? These are all things we take for granted. I'm afraid to take the bus, no joke. And so if you just imagine yourself as a refugee coming here and trying to navigate that system. Not to mention that, again, although there are all these public services that may give a refugee money, it's not enough. I'm sure a lot of people have read books about people who have tried to survive on minimum wage, et cetera, et cetera. And there's just not enough money. So there's a lack of money and there's a lack of knowledge, which makes moving around and a sense of community very difficult. So trying to get to and from your job, and then also trying to get to and from friends, or to try to establish some sort of community. What about the food here? So our food's a lot different than Somali food, and it's very important and very ingrained in their culture that their food is in line with the tenets of Islam. So food has to be served halal. There's a lot involved with that. The animal has to be, if it's meat, the animal has to be killed in a certain way. The blood needs to be drained. The neck has to be cut. The windpipe has to be cut. It can't be a cut of the spinal cord. They cannot have alcohol. And there's no pork, because pork is considered a dirty animal. And so, and their food is basically, rice, spices, peanuts, there's halva, and actually according to USDA recommendations, probably wouldn't meet the requirements for a well-balanced diet. And so you have all of these nutritional challenges. So, they don't have the knowledge or access to their food, and they're already sort of at a setup for nutritional deficiencies. The other thing, anecdotally, in talking to populations, is that so the rent is paid for about 3 months, and then they're expected to pay for the rent on their own. Well, they may get SNAPs or the food stamps, and if they don't have jobs, they may start selling their food stamps for rent. And so anytime you see a refugee here, you should think immediately about food insecurity, because it's a real problem. The other thing, just talking about the pork again, is a lot of people, in terms of their knowledge of things here, they don't know what pork is in. Is pork in toothpaste? Is it in vitamins? Is it in yogurt, in pasta? So these are a list of things that people have asked me. Sorry. So again, a lot of food insecurity, and that is so important. I think people would choose not to eat rather than to eat something that was not halal. So what about jobs? So Molly was asking a little bit about the the process of coming here. How long does it take? Well, a lot of refugee camps have schools set up. They have these internal networks, and it's like sort of a mini community, or actually not mini. I mean, it can be quite large. A lot of the adults that come over will say, "Oh yeah, I was a teacher in the refugee camp." A lot of the refugee camps don't, though, and are less organized. And there may be some clan differentiation, and I don't know, and there may be certain Somali refugee camps that are well organized and others are not. But I can say that a lot of the patients that I have seen, there is a definite lack of education. They don't speak the language here, so you have a lack of education. You don't speak the language. Again, the transportation, it is very hard to get a job. So there are, as I said, the VOLAGs have employment training and that type of thing. But again, where the rubber meets the road, it becomes very, very difficult. And then the last thing anecdotally I've heard is it's very common for Muslim women to wear a headdress for respect to God, but for certain jobs that may be considered a risk for accidents at work. So what I've heard is, being a checkout clerk is not possible because the headdress may get caught in the band that sort of moves the groceries, just as an example. So what about community? I mean, there are so many Somalis here now. There are a lot of Nepalese here. There are a lot of Burmese here. What about sort of forming a community where people can talk about these problems, can self-educate on education, or trade tips on how to get jobs, or trade tips on how to use public transportation? So again, here is, I was alluding to before, if you were to set up a community center, you would need someone that understood the American system and how to fund it and how to procure the space, et cetera, et cetera. And there's a distrust from organizations in the U.S., and it starts at a very early time when someone comes to the U.S. And then the second thing is, as I said, for over 1,000 years, the clan culture has been a very deep and-rooted thing in Somali culture. And so that has transferred over here. And so there have been Somali community centers here, but they have fallen apart not only because of the distrust of sort of Western structure, but also because of some conflict in between different clans. So that has become very difficult as well. And then for me, obviously I focus on kids, and so education is a big problem. So not only education overseas, but education once they get here. So what happens to a 13-year-old when they get here? Well, they don't say, can you pass this test and you'll go to that grade level, or they don't say, what grade were you in Kenya in your refugee camp? They say, you're 13, you're in 7th grade. So they may have not had any education at all. And they don't speak the language. Their parents don't speak the language, so the parents can't help with the homework. Transportation is an issue. Lack of resources, lack of community center, that type of thing. And so it's a setup for failure. So this is just to illustrate. I'm going to try and tie up in 2 minutes because I don't want to have time for questions. But again, just to say the social history is so important, and that's what I hope I gave you a picture of, the whole process and where people are coming from and what the challenges are here in the U.S. in terms of a person's well-being. And then I just want to touch quickly on the gender differences in Somali culture and talk a little bit about female circumcision. So culturally, if you meet someone who's Somali, and myself as a male, I'm not supposed to make eye contact with a woman. Men are supposed to make eye contact with men and women with women, but not cross-gender. In terms of relationships professionally, in terms of being a doctor, it's better for males to be with males and women to be with women. It's interesting in my experience here talking about female circumcision. So if you look at the data, up to 98% of females in Somalia are circumcised. And if you ask a lot of people here, they'll kind of say, no, we don't believe in that. But I have a friend of mine who's an interpreter, and she'll say to me, she's a Somali refugee herself, she'll say, you really need to ask, keep asking, because they're hiding it from you, because they know that that is not looked upon favorably. And so she'll dig a little bit deeper and say, yes, okay, I was, or she was in Africa, or yes, we want her to eventually. And so it becomes there's a lot of stigma surrounding that, but there's a lot of cultural pressure within that society for female circumcision. And a lot of it has to do with, it brings the family great shame for women not to be a virgin when they're married. And one way to ensure that a woman has not had coitus is to sew them up, honestly, which leads to, a lot of health problems, obviously for a lot of human rights issues in that. I'm trying to be objective. It's hard to be. So, as I said, the panel physician over the seas there are different types. Type 1 is removal of the clitoris. Type 2, labia minora and clitoris. Type 3 is basically with or without the clitoris, but basically sewing them up. So this has a lot of health implications, UTIs, if they're ever pregnant, and birth implications and that type of thing. This is to show the belt of where this practice takes place in Africa, and you can see in Somalia up to 98%. All right, that's it. What questions do you guys have? No, go ahead, Lisa.
You mentioned some of the resources here in the Denver area, Denver Health, and some, but I think in the community, like Fort Worth and Greeley, where there's a number of refugees there, and when you have knowledge of the resources there, I think healthcare and opportunities are limited in general, so I'm concerned for the refugees there.
Yeah, so there's we actually meet. There's one other place. I think it's maybe Fort Collins. There's one other place in Colorado that does a lot of refugee screening. In terms of resources themselves, like VOLAGs and stuff like that, I don't know. That's a good question. We do meet once a quarter with some other leaders around the state just to talk about sort of the process of migration, but I haven't gotten so far to know what other resources are available for the people in terms of where the rubber meets the road. That's more sort of screening process type of stuff. That's a really good question, though. I'll try and find the answer for you. Yeah. Who else has a question? Yeah. So it was structured that Aurora Mental Health provided those services. So it used to be that the Colorado Refugee Wellness Center was a collaboration between the Colorado Department of Public Health and Environment, when they were doing the screening, and Aurora Mental Health. And I think that, so MCPN, it gets confusing with all these acronyms and players involved, but MCPN now is in that clinic, and it is in the same building as Aurora Mental Health. And I think that Aurora Mental Health still plays a vital role in terms of in terms of the mental health, both screening and follow-up after. It used to be Colorado Department of Public Health and Environment would have clinical social workers or mental health experts that would do a lot of that, but I think Aurora Mental Health is playing a unique role. I'm sorry?
That has to be done with interpretation.
Absolutely.
So who provides that?
So there are interpretive organizations here, which I think the VOLAGs help set up. So when these people come to their first screening visit and mental health visit, they have a live interpreter with them. Kristen?
It doesn't seem realistic that anyone would have a job in 3 months.
I know.
Are like 90% of them homeless? I mean, it doesn't seem like anyone.
Yeah, I mean, I think where there's a will, there's a way, and people find ways to survive or to put off paying rent, or maybe people who have been here longer loan other people money. I agree. It seems absurd, honestly, to me. Not only for someone to be asked to find a job in 3 months, but for a person with all of these barriers, maybe no education, doesn't speak the language, lack of transportation. I mean, there are so many challenges faced by these people. And there are a lot, if you Google online, there are a ton of refugee nonprofits and things out there to help, but it's complicated. It is really complicated. I have not, although I mean, first of all, you got a lot of families that are like, 10 people in a bedroom type of thing. And you get, I did speak with one man who was homeless for a long time and got on his feet, but now is currently lives in Denver, works at the airport, has to ride on a bus an hour each way. The bus costs him $8 an hour. He works for about 8 hours and gets paid about $8 an hour. So two of his hours in workday are just to get there and back. And then he's got, another 6 times 8, $48 for the day? I mean, it's kind of absurd. Very challenging. Yeah.
As a pediatrician, when you see the refugee children, are you seeing them, I kind of have like a multi-part question.
Yeah, go ahead.
Are you seeing them alone? And if you are, do they ask questions of you? And if so, what health topics are they interested in when they ask questions?
It really depends on the age, I guess. A lot of a kid, maybe 4 to 6 years old, probably won't ask very many questions. They're accompanied by their parent. And so usually in the room, it'll be a parent, an interpreter, the child, and yourself. And even the older kids, not many questions. And it's sort of like, kids are amazing. And sometimes, despite all that they have been through and whatever, they're bouncing around the rooms, playing with a bouncy ball or something, and just like vibrant, and maybe malnourished and whatever, but just smiling and laughing and being kids. And so that's like I love being a pediatrician. I don't know if you can tell that, but yeah, I think that's a really nice thing. But I haven't really gotten too many. I can tell you some horror stories, honestly, but I haven't gotten any really direct questions from the kids about health per se. Yes.
So, I was wondering, I'm from Somalia.
Yes, you can keep me honest. Tell me if I got anything wrong.
Well, the one thing I was a little bit not following is how well are you guys connected to the communities? Because I'm sure there's a bunch of people around Denver. And to be honest, tribal plays a big role in how we place ourselves, around, of course, my tribal. But within tribal, we're very strong when it comes to our community. And that's why you do not even see Somali homeless person, because we always receive phone calls from people asking, okay, are you in this tribe? We have someone in that tribe who's sitting on the street with his backpack. Can you come and get him? So how well do you guys communicate with communities within each tribe? I'm sure there's plenty, but how well are you guys connected with those communities?
First of all, thank you very much for that, because it's something that I would not know and adds such valuable insight. And I would say, as a very quick answer, not well at all. Not well at all. And I think a lot of people probably feel that they don't have time to actually, I have been in homes of refugees and have seen the conditions and that type of thing. I don't think everyone really necessarily can do that. And so where the rubber really meets the road, where you really actually see what people are doing, I think there's a big gap there. I'm not sure how to bridge that gap. So I know and am friends with one of the interpreters. I actually asked her to come today. I guess she couldn't come, but she gives me so much valuable information and insight to actually what the community is. So much of what I learned about, telling about the schools, she said they put them in schools. There's no one to teach them, and they don't speak the language, and there's no tutors, and et cetera, et cetera. So, I'd be open to any sort of,
And then my other thing
yeah.
would be, the biggest concentration for Somali refugee will be in Minneapolis.
Right.
And so how big connections, do you guys have any connection? Because I'm sure Somali in Denver is more lost. I came from Minneapolis, where
Yeah.
communities that taught me English as a second language classes, staying up to like midnight every night. But how, like I think the whole problem here is that there's no connections.
Right.
We have big communities playing big role in Minneapolis, but I'm sure they're not going to be able to reach the entire nation. So you mentioned someone's working in Denver Health.
Yes.
And you know if they're working with communities in Minneapolis?
Oh yeah, I mean, so in terms of health care, Minneapolis is a leader. You know, Minnesota is a leader, the state there, in terms of how they've assimilated refugees, and particularly in the Somali population. And it's kind of amazing. I mean, here we are in 2014 and sort of going through, as I alluded to a lot, it's kind of nebulous and sort of amazing that there are not better connections and a more structured way of assimilating people to the U.S. Honestly, I feel embarrassed, you know, when I go to some of these people's houses and I say, you know, this is our rescue mission from, you know, we're bringing someone to our country and we're putting people in these conditions. It feels embarrassing. It really does. And yeah, there should be, so not only sort of at a structural level from our point of view in terms of medicine and public health and that type of thing, there should be better structure, and Janine Young is working on that, because when she really started to delve into it, she was like, I can't believe no one's actually studied whether it's worthwhile to screen everybody with stool O&Ps or not. Someone needs to do that work. But then also at the community level, at a public health level, I mean, there should be mentorship programs, or, you know, it sounds like it's happening, but not in a structured way. Did that answer your question?
Yeah.
Okay. Go ahead.
I think we're unfortunately running out of time. I do want to make one statement, which is I think
Yeah.
ACC does like incredible work.
Good.
And they really do try to connect people with their communities. Unfortunately, they're only really paid a certain amount of time
Yeah.
after people arrive in order to help them. But they do great work in trying to make sure that people can see behavioral health. They have their own behavioral health people, and they have their own social workers that they hire. So there are some of the non-for-profit groups in Denver do great work, but unfortunately we don't have anything really else that we do. But thank you so much for presenting today.
No problem. Yeah, I didn't mean to insinuate, by the way, that anyone's not doing great work. It seems like
that we could do much better.
Well, I think it's to me it is probably that very well-intentioned people being overburdened. Mm-hmm. So, you know, I don't know the ins and outs of it, but I hope I didn't slight anyone in any way. So.
I had one thing just quickly.
Yeah.
I think there's another population that can help with some of the information. I'm a family advocate. I've been working for about 8 years with primarily Burmese families.
Yeah.
And some families from Ethiopia, but so everything you talk about I pretty much know and I've learned from the field. And I think some of these people who are working in the home, because a lot of the agencies are doing great things, but they're overloaded. There's so much to do. And refugees are helped for that first year. But after that first year, sometimes they have to go on their own, and that's where volunteers or different people come in to try to help them navigate the services and deal with healthcare. But that's another group that maybe you can tap into.
Good suggestion.
Thank you so much.
Thanks.